Okay, Dr. Taylor, let's see. So you're ready to go. So he's going to, Dr. Taylor, as you know, always I like to say that first person who did an lateral surgery in the American soil, I mean, we're talking about US, it was Bill Taylor. First paper published on the real literature on the world, Bill Taylor. So he's a monster on this. Everybody learned from him, and he's an amazing on the podium. Everybody loves his talks. He's very articulated. Everybody love him. He if we were like a Hollywood guys, he will be Oprah. Okay, so go ahead, Bill.
Well, I appreciate that one. I have absolutely no idea how I can keep that up. You know what I mean? I would say that I'm going to try to stay to 10 minutes, which is probably going to be the most important thing I can do here for everybody. I also, don't forget, I did the first PTP in the United States too. So we're going to have to, start adding to that list.
I have to put that one on my repertoire.
On your repertoire? All right. I appreciate talking about the TL junction. There was one question earlier about prone transpsoas and doing the TL junction. It's absolutely fine. I have done discs at the upper level of constructs. I've done thoracic discs and partial corpectomies in that spot with posterior percutaneous fixation. The same thing and the lung, all of the structures when you get prone is the same thing that happens to the retroperitoneal space in the abdomen in the prone position. So everything tends to fall away, and it makes it much easier for you to do the procedure. So my talk is not specifically about prone and the TL junction, although there was a question about it earlier, and I would just say that it's not a problem. And I would also just comment again about the retractor and other systems is that the purpose-built retractor for the prone also prevents the anterior migration, it prevents the pullout, and it does a whole lot of other things. So it really works well in this situation. At the moment, we don't have a great answer for a large or a double level corpectomy or something like that for a bigger tumor. So I've been doing those a little bit differently. Talk about that in a second. I would say that in 10 minutes, I won't go through cases, and the TL junction is always a concern for everybody. I think the most important thing is really the anatomy. So I would spend probably the whole time really just talking about the anatomy so that people understand it. The tendency when we do a surgery is to plan and to say, well, I'm going to do this and I'm going to do this level and I'm going to do that. The problem with the TL junction is you might open up and you might look and you might see the diaphragm, and you might do it on the next case and you might not see the diaphragm at all. And then you might be in the retroperitoneal space, or you might be in the pleural space. So I think it's really appropriate and very important for everybody to be prepared to work in and around all of those spaces. And if you can do that and you can understand the anatomy, then you can deal with whatever you're faced with at the time of surgery. Because at the time of surgery, you may not have what you planned beforehand. And the anatomy is pretty simple, and it's pretty straightforward once you get started. So the diaphragm really sits like a big bowl in that spot. It sits up on the top. It goes down to the 12th rib and attaches. And in fact, you can have a diaphragmatic recess in some people down to the L2 level. So in fact, people that are doing L1, 2 discs and other things may be actually in the pleural space in that spot. But think of the diaphragm as a large inverted bowl, which then contracts to increase the volume in the lungs, and then that causes negative pressure, and then air comes into the lungs. So, we don't really have any way to make things, pull things in. So the bowl flattens out and you get lung expansion, and the air gets sucked into the lungs, and that's now the diaphragm has multiple attachments. The most rigid ones are sort of around the spine and around the vessels that go through the diaphragm, which we'll look at in a second. The ones that we really deal with much more frequently are the lateral attachments, the costal attachments laterally, and those are the areas that really can be removed without any trouble. The old adage where you sort of have more than about 4 or 5 centimeters of tear in the diaphragm is pretty significant for repair. And as you know, the vascular surgeons or urologists or general surgeons would split the diaphragm, tag it on the way in, and then sew it up at the end, which works fine. We don't really need to do that with minimally invasive surgery, and it's pretty simple to get down to that spot. And I would encourage you to really think about the anatomy. I mentioned earlier, it's really important to do cadavers and to go to the courses that are offered by companies and institutions and like this, the Seattle Science Foundation, where you're really looking at the anatomy and trying to figure out exactly what you're going to deal with, because you're going to have to look and deal with it, and it might be different on every single one. Well, how do we get down there, and what does it look like? This is sort of an old picture, and a lot of the stuff we've seen many times before. T12L1, let's go back one actually, and just look at this, because you have to sort of remember what you're dealing with, whether you're going from the right side or the left side. You absolutely can go from the right side. The left side is a little more traditional for 2 reasons. Number 1, the liver is not there. Number 2, you're dealing with the aorta rather than the vein, and it's much easier to manipulate and move out of the way spot. So I would think about where you are on the left or the right side. And on the left side, you're going to see the diaphragm down to about T9 or T10. And on the right side, you can see it up a few levels higher. But to really deal with the diaphragm is really T10, 11, and 12 below. And on the right side, sort of up to about T9 or so. And those lateral attachments out on the costal junction is really what you're looking at. So how do we get down there? There's sort of basically 3 separate pathways to get down, which I talk to people about. And we can look at it. One, if you're above the diaphragm, you're in the pleural space. All right, so within the pleural space, and that's really T12 and L1 on the left side occasionally, or a little bit higher. A T12L1 corpectomy, you can often be in the pleural space, or a thoracic disc or something much higher in that space. So in this area, you're going to be in the pleural space, and that means that you have to deal with really 2 structures on the way in. One, taking the bony structures, the rib, and the other is the soft tissue. So remember, the lung is covered by the parietal and the visceral pleura. You're dealing with the parietal pleura. I often tell people that the parietal pleura is just sort of like dealing with the dura. You should be careful, but the difference is you don't need to repair it. You don't need to do anything about it. But if you strip the pleural space and you open up that area in the retropleural space, then you can deal, and you can never actually enter the pleural space and never actually enter the lung. It's often damaging the parietal pleura is not a problem. Damage to the visceral pleura is where you start to worry about pneumothorax and other things. So damage to the parietal pleura and air getting into the lung does not cause any problem. If you damage the visceral pleura, so you need to be careful with the lung. You treat gently, wet laps, retracting out of the way, and being careful with electrocautery and sharp instruments. But it's not a problem. You don't need to do any double lumen tubes or anything. You have enough space to work no matter where you're at. I usually go between the ribs if I'm just doing a discectomy. And if I'm going to do a corpectomy or something more difficult, I will always take a rib. Quite frankly, I found myself taking out a rib almost routinely now, because if you take out the rib, the patients don't really notice it. But if you break a rib, they definitely notice it. So I actually routinely almost always resect a rib on the way in, no matter what I'm doing, only because I've broken a couple of them and had very unhappy patients. So even doing a discectomy, I'll often now do that. But so the pleural space, you're above the diaphragm. And talk about going trans-diaphragmatic. A lot of people don't sort of realize this happens mostly when you're doing L1, 2, and other levels, especially on the left. The diaphragm, like a bowl, you're going through sort of the edge of the bowl as it comes over that inverted bowl where that arrow is. So essentially, you're going through the pleural space, through the diaphragm, and into the retroperitoneal space. I find this to be an easy approach, and I often will make, it's the only time I now make a second incision to put my finger in that space. And I push the diaphragm up with my finger, and then I enter the retroperitoneal space through the diaphragm in the upper lumbar spine levels. And it's a very easy, it feels the same as entering the retroperitoneal space, but you can check with your finger and pushing it up and push the diaphragm up and out of the way, but you're sort of entering it up in that spot. And once again, you don't really need to worry about chest tubes. You don't need to about the working just essentially like you would a retroperitoneal incision. So the last way sort of is when you need to remove or you need to develop a place in the pleural space or in the diaphragm. So the picture on the left with the finger is really the pleura and the diaphragm. Those attach very easily. They detach very easily. You work your finger and a sponge stick along the lateral edge of this space. You create a retropleural space or a retrodiaphragmatic space, and you move the diaphragm forward. You don't need to reattach it. You don't need to repair it, and it will move as a single unit on relieving the costal attachments. And those costal attachments represent less than 10 to 15% of the diaphragmatic attachments and make no difference at all. And once again, it's an easy space to develop. If you have to remove the diaphragm, you can't go through the diaphragm in the retroperitoneal space, can't push the diaphragm down to get into the pleural space. You simply remove the costal attachments laterally and push the diaphragm forward. And if you can understand those little steps in the anatomy, then you turn the procedure into just what you've done before. And this is kind of the picture that you get. You move the diaphragm anteriorly. You create a working space. That's the dura down there, posterior and anterior. You can gain access. I always resect a rib in this case, making sure to cut the rib as far possible proximally towards its attachments, because if distally, the rib will be loose. And you can enter this space and create a working space going all the way down to L2 and then all the way up as far as you want to in the thoracic spine. And that can either be moving the diaphragm forward or moving the pleural space forward. And that anatomy, once you see it, look at it, is really, really easy to work with. It's not really confusing. You do need to make sure, just like when we work on the retropleural space or the retroperitoneal space, you need to look and see where the vascular anatomy is. It's easy to see where the artery is. It's usually very, very far lateral in the upper levels. Someone mentioned before, I think it was Louise, was asked about PTP and how far you could get up, and about T5, 6 is really the limit. And I usually go from the right at the upper levels because as you can see, the aorta extends all the way over to the left-hand side. And then once you get about down below 7, 8, or 9, then you have enough space to work, and the aorta moves to the midline to pass through the diaphragmatic attachments. So, sorry, I don't know why I keep losing that picture. So what are the specific things in the in this space that we have is do a few there for a second. Sorry, pleural fusion is really the biggest thing that you need to worry about. People are always concerned about the pneumothorax because it carries a connotation of danger. It carries a connotation of sudden issues. It carries a connotation of needing to do another procedure. But in fact, if you do not damage the visceral pleura, a little bit of air in the lung is not a problem. It doesn't create a tension pneumothorax. And it's much more likely if you're dealing with an infection or a tumor that a pleural effusion becomes much more important. I don't place chest tubes. I simply place a 10 flat Jackson Pratt drain into the pleural space or the retrodiaphragmatic space or whichever space I'm working in. I put it to bulb suction, usually get a few bulbs of air out, and then mostly you drain fluid after that. And you have to leave the drain in until it gets down to around 100 cc's. You can probably take about 200 cc's in the pleural space. But pleura is the biggest problem. Pneumothorax, if you do damage the vis pleura, you need to place a chest tube, but it's very, very unlikely that you're going to do that if you have, if you're safe at all. CSF leak is really the biggest issue. Remember, the CSF leak is a problem because every time you inspire, you create negative pressure. That negative pressure then sucks the CSF into the chest area and into the lungs. And into that retropleural space, and it will drain there forever. I've gone back to repair them, which you can sometimes do. I put a lumbar drain in, which you can sometimes do. I put a lumbar peritoneal shunt in, and in one case, I had to do a pleural peritoneal shunt to drain the CSF. So I'm very, very careful about a spinal fluid leak. The vast majority of times, it'll be fine with some fibrin glue and Duragen. And being careful. This is just the light inside. An old picture of what you're looking at: the diaphragm, the chest tube, a chest in that area, and the lung cavity. These are just a few cases looking at what we're going to do. Left side retropleural approach at T12 L1 with a corpectomy. You can get a nice dissection. You can see these pictures on the upper left with the retractor. A good exposure, 2 levels without any trouble. The diaphragm is really the shadow that you see in there, and then quite easily percutaneous pedicle screws. Looking at that after. Another procedure and with a T12L1 in the same exact area. Working down about L2, don't forget you're going to have to sort of deal with a rib at that level, probably the 10th or 11th rib. You'll probably have to start dealing with the plexus and the psoas muscle. The diaphragm is actually extending down along the spine to about the L2 level also. And then get it. And that's the procedure that we're looking at, and then percutaneous pedicle screws. Quickly, you have quite a bit of literature which supports you in doing work in the thoracolumbar junction from a minimally invasive lateral approach, both looking at sort of, are we going retropleural, are we going retroperitoneal, and exactly what space you're going into. And you can see down at L2-3, you're always really retroperitoneal. As you extend up, that sort of changes, and that's why at T12 and L1 and L1 and L2, you need to be prepared with what anatomy you get and what you find, rather than trying to make a specific plan beforehand. And then there's lots of papers about looking at that for trauma. This is a case, I think this is a paper that Juan published from there, or else he gave me the case. I always add this because I see so many people, they get into the thoracic spine and then they start doing risks and think, oh, a thoracic disc is just like a lateral procedure. It's not. It's a much more difficult procedure. I find it very time consuming and difficult. And I would tell you it's not a standard lateral procedure. It's something that you need to really work at. I resect the pedicle. I take out the calcified disc last. I open up that space. You don't really need any hardware, but you really have to look and see what you're doing. And that's sort of, you can see the big calcified disc we have back in that spot in this picture. And you want to create a working channel and deliver the disc into that space. The last thing you do is take out the disc, and you very, very carefully dissect it from the dura and the thoracic spine are in that location. And always CT scan, plain films if you can see it. The calcifications turn it into a completely different operation. I usually put a cage or something in there, but remember, you get no help from indirect decompression. So it has to be a direct decompression after drilling out the pedicle in that spot. Yes, it is one. You gave me this paper a long time ago, sort of looking at it and taking out the pedicle and sort of looking in that spot. So I hope I stayed. I didn't check my watch exactly. I went over a little 10 minutes. This is just usually what happens is you start with some books, food, and then you drink some wine, and finally you get ideas. And and this is what happens when you drink too much wine. So thank you very much. If you have any questions, I'd be happy to answer them.
Bill,
Yeah.
it's Neil.
Hey, Neil.
Well, thank you. That was really elegant. I loved it. You know, I've had a few that have had thoracic effusions. They
Yeah.
have come like 4 or 5 days later, and they do fine for like 2, 3 days. Have you seen that? And what do you think it is? I mean, I have my thoughts, but I've definitely seen that.
Yeah, so I would only say, surgeon doesn't really give you very many advantages, except what happens as a neurosurgeon is you have to deal with shunts. And that's like the worst possible thing. And when you deal with shunts, they end up sometimes in the thoracic cavity. And what I've found is that the thoracic cavity can only take so much fluid, and it's about 200 cc's. So what happens is you get, 150 cc's one day, you get 200 cc's, and it barely drains it, and then it just slowly builds up over time. So it might drain 100, and if you have a tumor or something in there, it even decreases the ability to drain it. So it takes a couple days for it to build up enough fluid so that it becomes symptomatic. So I leave those drains in for 3 or 4 days, and I make sure that they're less than 100 cc's. I just think it's a matter of not completely dealing with the pleural space and the fluid, and then slowly builds up over time.
Right. That's why we stopped going 12-1 and above in deformity.
Yeah.
Because it wasn't worth it. 5 days later, we'd be tapping them. And a 70-year-old is set back 2 weeks. Literally gone.
Leave a drain in until it goes down, because I mean, I can't tell you how many times, during training, you'd put a shunt in the CSFs, you do a ventricular pleural shunt, and you put the shunt in the thoracic, and then, they do great. And then 3 months later, they'd come back with a giant effusion. And it's just because it doesn't drain the entire amount of fluid. And the pleural space only can do about 100 to 200 cc's a day, depending. And so you've got to drain those until they really, for a long, long time. And that's what I do. And that's actually why I don't put a chest tube in too, because the chest tube is so uncomfortable and so big if you put a soft drain in. And I've tried a bunch of different ones, the cardiac drains and other things, which also work. You put a soft drain in, and you can leave it in there for much longer, and it doesn't bother them. Anyone else? Good. I see Rod up there moving things along already.
Dr. Taylor, I've got a question for you. Cristiano's speaking.
Yes.
What about to find the retropleural space, to retropleural approach in prone? Do you think it's feasible? Did you do that before? And because, to find the retropleural space, usually you go more posteriorly, following the anterior part of the posterior rib, right? How to do this in a different decubitus than lateral?
Yeah, I mean, so I would say, first of all, I mean, as Luis said, the group that we're working with, we've done about 1,000 cases, and I've done about probably close to 75 levels now, and I've a handful of those in the thoracolumbar junction. So have a huge experience, but the ones that I've done, I treat them exactly the same as the lateral, and that retropleural space, you can absolutely easily develop it, and that's one of the reasons why I take a piece of rib, and because you can feel the retropleural space push things inferiorly. So instead of moving it laterally, you push that space inferiorly and create it, and it really, really works well. And I've done that a handful of times, especially usually at L1-2, T12L1, and then a higher thoracic disc. And you absolutely can create that space. You do absolutely want to rotate the bed. So that was one thing that sort of Adam said, that he had to raise the bed up to orthopedic height, we call it. But we've pretty quickly rotated the bed. And actually, I sit for these procedures, and I rotate the bed a little bit more than Louise does. And I sit and look down the tube at about 30 degrees. And then you really have to make your orthogonal. Canality is marked by your retractor position. So the retractor is what guides you. You lose sort of your straight AP and lateral. So the orthogonality stays from the attractor, so it becomes very important to put that in correctly.